Very good morning and welcome to ISO MVR CanCon 2024. Okay, my first question is to Dr. Chandramohan. So, what do you think is the burden of the metastatic colorectal cancers presently in India?
Yeah, I think more than Indian figures, Kerala figures are more alarming because colorectal cancers are the third most common cancer according to the population-based cancer registry of Kerala, both in men and women. This is unprecedented. Nowhere in India this figure is there. And as per the records, we may be having nearly 3,000 to 5,000 new colorectal cancers every year. And 40% of them will be coming with metastasis and recurrence. And it should be roughly 1,000 to 2,000 patients every year. And the treatment of colorectal cancer recurrence is very difficult because, first of all, the survival is going to be much less. At the same time, the advancement of all medical, surgical, and radiation oncology has made it possible to treat such patients, at least a subset of patients, to get the permanent cure.
Yes, sir. So, what do you think is our roadmap to future? What are we looking at?
I think the roadmap to future is to have more facilities where specific cancer care is provided. And it's a high time we have to move towards organ-specific management of cancers with all experts sitting together. And the role of the tumor boards is very important. The multi-modality care, we need to sit together and decide for treatment rather than a single person treatment. And also we should have continuum of care in terms of supporting the patients after treatment regarding the loss of quality of life and somebody is having advanced disease, supporting with the palliative care. It has to be a continuum of care which is needed, and there are many lacunae we have to fill in those lacunae.
Yes, sir. I totally agree with you. So, coming to Dr. Rao, sir, what are the surgical challenges we face while we are doing a salvage echophagectomy? Because you know all these cases are post chemo RT, chemo radiation. So, what would be your tips and tricks for the youngsters?
The moment you use the word salvage, we need to understand that it is the last chance. And in esophageal surgery landscape, it is in two situations. One is when the patient has undergone complete chemoradiation, a definitive therapy as the primary therapy, and still the disease is persisting. So, which means here the patient would have received very high dose of radiation therapy and also chemotherapy. The second situation is when the patient actually responded, but relapsed later on, about 2 years, 3 years later on. Both of them are significant challenges because of multiple reasons. One is, at least in India, squamous cell carcinoma is more than adenocarcinoma. So these patients are elderly and many of them are tobacco abusers. So their lungs are not the best. And over a smoker's lung, when you do radiation therapy, there is significant amount of damage that happens with the radiation therapy itself. So after that, when we operate, there is loss of blood supply and nerve supply to the tracheobronchial tree and the eventually the lung. So these patients develop significant lung problems amounting to about 50% of them. So it becomes sometimes difficult to bring them out of this problem. So this generates fear not just for the patient but for the medical professionals also. So that is the reason why this problem has not been addressed well enough in the past few decades. We understand that in institutions of excellence, I would call them islands of excellence, where a lot of surgeons, physicians, and radiation oncologists work together as a multidisciplinary team, have achieved excellent results by being very aggressive in a select group of patients. So after radiation therapy, you discuss between your colleagues and then prepare this patient well. It's called prehabilitation, and assess the tumor well. And in a team, when you venture to operate these patients, actually 50% of these patients do well in the long run. So it's a very high cure rate, but what you need is a good teamwork and some commitment from the hospital team and the society.
So, do you think, sir, is it possible in a resource limited setting to carry out salvage surgeries like you mentioned
Yeah,
before?
what is important now is resource limitation is a secondary thing. What limits us is our own thought process. What is important is, even in a smaller place, if there are 3 surgical oncologists or upper GI surgeons, they should come together for this cause. If they come together, then the facility need not be a very high end facility at all. What you need is a ventilator probably in the ICU, and a good instrumentation that is generally necessary for any cancer surgery. If there is a cancer hospital and if there is a team, this is something that is achievable. What is necessary is to build up your attitude and build a team to fight this disease. See, we cannot give up and send these patients for further radiotherapy. Many times they would have received 60 gray radiation therapy, after which you cannot do a similar dose. If it has relapsed or persisted after the first radiation therapy, it would continue to persist after the lesser second dose of radiotherapy. And chemotherapy in this situation would not work at all. So only thing that is remaining is surgery. And I think it's for the surgical team, you must develop a tendency to give a chance to the patient, even if it is high risk, not to give a chance to the tumor, give a chance to the patient. That is something that we must believe and practice.
Yes, sir. Well said. So thank you, Dr. Rao, and thank you, Dr. Chandramohan, for your
Thank you.
insights.
Thank you very much. Is that